All right, we're going to get started for people that are here as well as for our people that are joining us video teleconferenced from the external sites throughout Washington, and I think we usually have a few that get tuned into Alaska, so we'll see. Hopefully you guys are all, external sites are getting connected. I'm David Eaton. I'm one of the nurse practitioners at the Autism Center, and I'm filling in for Jim Mancini, who is on a interesting kind of, what would we call it, exchange program. He's in Egypt right now, actually doing some a person from Egypt, a professor from Egypt, came and visited us over the summertime, over the fall to summertime, and now Jim Mancini is back over there in Egypt, providing his insight to what they have going on for autism over in Egypt. So anyway, I'm filling in for Jim tonight. Just a quick reminder for all you here for the first time, or a reminder for those repeat people, if you have questions, feel free to ask. And if you are asking questions, no personal health information or private information. This gets posted onto YouTube, so just keep that in mind when you're asking questions. And without further ado, I'm going to introduce Dr. Eric Boelter. He's here this evening to talk about ABA, Applied Behavior Analysis in Disruptive Behavior. Pulling up my little bio on Dr. Boelter. So Dr. Boelter received his Ph.D. from University of Iowa and then continued his postdoctoral fellowship at Johns Hopkins University School of Medicine, as well as Kennedy Krieger Institute, two very prestigious areas over there on the East Coast. Following his fellowship, he remained as faculty at Kennedy Krieger until we pulled him away to Seattle Children's. And currently he's the Clinical Supervisor of the Biobehavioral Program at the Autism Center, and also a clinical assistant professor through the Department of Education at the UW. His research and clinical practice focuses, as you'll see tonight, on the use of applied behavioral analysis to assess and treat individuals with autism, as well as other developmental disabilities who engage specifically in severe disruptive behavior. So hopefully that applies to all of you to some degree, maybe to gain some information tonight. And without further ado, we'll welcome Dr. Boelter.
Thank you. Thank you, David. And thanks to Jim, who stayed on me long enough to where I got in here to give this talk. I've been meaning to do this, so I'm glad I had an opportunity to come and speak tonight. So as David said, I'm going to go ahead and talk a little bit about the use of applied behavior analysis to assess and treat severe behavior. And just an overview here. I'm going to start by talking about just some basic principles of behavior that applied behavior analysis uses. And then I'm going to quickly go into the idea of behavioral function and how we use what's called the functional behavioral assessment process in our assessment. Then I will talk about how function then helps us develop treatment and how that leads to treatment. And then I'll finish up tonight with talking about just a review of our program, the Biobehavioral Program over at Seattle Children's Autism Center. And then there'll be time for some questions. And so a lot of what I talked about tonight in this part one, as I look at this, the 200 series, is the part one for the challenging behavior is I'm going to focus mostly on the assessment process and what that means. And ways that families can actually do some of that. And Dr. Nancy Rosenberg from the UW is going to be coming next month in March 17th, it looks like, to talk more about some practical treatment strategies once you have some of this initial assessment information. So that's kind of how we put those two together. Okay. So just to start us out here, talking a little bit about the science of behaviorism. The framework that we start from as behavior analysts is that all behavior is a function of an interaction between the environments and behavior. It's lawful, it's predictable, it can be brought under control, and there's various events, things that happen before a behavior, like antecedent events, and things that happen after a behavior, such as various types of consequences. Some of the basic principles that we use are things like rewards. A type of reward is something that occurs as a consequence after a behavior that increases the probability of that behavior occurring in the future. An example that we might have here is the child completes homework to earn access to video games. They complete it, they earn access to the video game that they like, and the next time the probability that they complete their homework goes up. There's also on the other end punishment procedures. These are consequences that occur after a behavior that decreases the future probability of that behavior occurring. An example I gave here is a child stops hitting their sibling during play because their parent puts them in timeout when that happens, and they want to avoid that, so they stop the behavior, so they stop hitting. So, we use these principles as behavior analysts, but what is the process here? So applied behavior analysis uses these specific types of procedures. We evaluate whether the changes that occur in the behavior are actually due to our application of those procedures, and we do that through something called single case design that I'll talk about in just a minute. And we also want to use these types of procedures to change socially significant behavior in some meaningful type of way, something that really matters for individuals and families. As I just mentioned, we try to demonstrate relationships between behavior and environment, and we try to do that through what we call using single case design. And really we want to see these functional relations, so the changes in the behavior vary based on how we're altering the environment. So just a couple of examples here. When I talk about single case design, well, what does that mean? And the top example would be an example of how we try to replicate a treatment effect. Really, it's all about replication when we're talking about single case design. So in that top panel there, you see kind of baseline behaviors, and then some treatment was in place, and then you go back to baseline, and then you go back to treatment, and you replicate your treatment effect in those two treatment conditions. The bottom panel there looks at some type of baseline measure where you might be evaluating the effects of two different types of treatments, so treatment 1 and treatment 2. And then you would be replicating the effect in that bottom panel because you're toggling between the two treatments. So behavior analysts like to see changes in behavior based on changes in the environmental behavioral mechanisms. And so that's what we mean by single case design, showing some type of a replication of our effects. So there's a lot of scientific support for applied behavior analysis. The Journal of Applied Behavior Analysis started in 1968. So we have several years worth of this kind of research across various settings, as you can see here: home, school, outpatient, inpatient hospitals, various types of behavior. There's a lot of severe behaviors, aggression, self-injury, things like that, but there's also increasing adaptive behaviors such as academic skills and so forth. And it's across a lot of diagnoses. We hear a lot about ABA and autism, but there's decades worth of research to suggest that it'll work with lots of different kids. ADHD, Down syndrome, various types of genetic syndromes, individuals' intellectual delays, autism, of course. And so it's not just tied to autism. So when we think about the methodology that we use as it relates to assessing and treating severe behavior, we think about behavior being a function of some of these things here: genetics and physiology, past environment, so the history that a particular individual has, as far as reinforcement history and so forth for behavior, and then immediately what's going on in that moment at that time. And this bottom phrase here is really kind of the key to all of it. And it's that we're not so worried about what the behavior looks like. That's important because we need to track it. But knowing a child is diagnosed with autism and is aggressive tells us very little about how to treat that child's aggression. Knowing the function or the reason why that child engages in aggression, that particular child, tells us everything we need to know about how to treat it. So it's really more about the function or the why. Why is that child engaging in the behavior, or that adult? that's more telling than what the behavior looks like. And so that's what we really focus on. And so this is just a little bit of a recap of what I just said here. So the reason, when we talk about function, it's really, the reason why problematic behavior continues to occur. We use the term social functions when we're referring to environmental events that cause the problematic behavior to kind of continue to occur. And then how that leads into treatment is that treatment is based on then identifying the function specifically and not so much about what it looks like. So this is just a quick little diagram of how we conceptualize a particular problem behavior. And so we have kind of under the S is kind of the antecedent or the front end type of things that might trigger some problems. We often talk about that as triggers. So down here at the bottom we have people, tasks, settings, prior situations. Those precede a response or a behavior. And then we have the O as the organism. That's the stuff that comes with the individual. So, what's the history? What's the physiology going on? Does the child have autism, or do they have Down syndrome, or do they have some other genetic syndrome, and how does that play into it from a physiological perspective? What's their skill level, and so forth. And then you have the response, and then on the back end you have consequences. So once that behavior occurred, was it punished? Was it reinforced? Was it placed on extinction, which is just a fancy way to say nothing happened, they didn't get any kind of response? And so when we really dig in and start to manipulate things to do assessment around why the behavior is occurring, we're kind of playing around with these components and then watching how the behavior changes. And we'll talk a little bit more about that as we move along here. So when we talk about functions, what are some common types of functions that we think about? Well, there's what we call positive reinforcement. That's the gain function. So a child might engage in disruptive behavior to gain access to attention from peers or from a parent. Or they might engage in problem behavior to gain access or maintain access to some type of preferred item or a preferred activity that somebody's trying to move them away from. Negative reinforcement is the escape function. This would be problem behavior that occurs to allow a child to escape or avoid some type of a non-preferred task or activity of some sort. And then there is the automatic functions or automatic reinforcement. These can be both kind of positive and negative, but a common example of this might be, some type of an internal state. So we know that sometimes children with intellectual delays and vision impairment might press on their eye because it creates a little bit of light that they might enjoy, and so they keep pushing on it. Not because it's getting anything in the environment, but it's making an internal change. Or if we have a mosquito bite, we might itch our mosquito bite, not because somebody's giving us attention, but because that behavior in and of itself is reinforcing. It relieves my itching, or it feels really good. And so we keep doing it even if nobody's around, because it's an internal change that we either like or it attenuates pain in some way. So let's just talk a little bit about some examples here. So we take the behavior such as banging, a child who's banging their head on the floor. We can say, well, that child's banging their head because they have autism. And it really wasn't all that long ago that people said that kind of stuff. Or we can think more functionally about it, and we can say, well, if we did some observations and we saw that child might bang his head on the floor because school staff stopped presenting them with task demands every time they do that. Because they're getting elevated, so they remove the task and they tell them to take a break until they're maybe ready to work. So if we're thinking about that example, what type of reinforcement might we think might be happening in that example that would be maintaining the head banging? So possibly the escape function, negative reinforcement, escape from work. If we reliably observed that every time that child was presented with a non-preferred task, they started banging their head, and that was removed in some way, even if by good intentions, we need to get them to a secure space, we need to block what they're doing, but really the work goes away, then what might be happening is that child's head banging is being maintained through negative reinforcement in the form of escape from non-preferred tasks. So another example, a child that hits peers at school when that peer attempts to touch their toys while they're playing. What will we think about for that form of reinforcement? Maybe I heard somebody say the gain function. Yeah. So positive reinforcement in the form of gaining, or in this case, maybe maintaining access to preferred toys. That child wants to play with those toys. That other guy better not come over and touch him, or I'm going to hit him. That child goes away, and I maintain access to my toys. So it's a form of positive reinforcement. Another example here, a child screams at home most often when they're transitioned away from the TV, or when their mom attempts to have a conversation on the phone or with other people. So a couple things going on here. What are we thinking about here as far as function? Maybe a couple kinds of gain function here. A couple of things going on. So the tricky part about this is I wish every kid I ever ran into only had one function for their disruptive behavior, but sometimes they don't, right? Sometimes they have multiple reasons. They use it for lots of things. And in this example, it might be that the child's using it to maintain access to a preferred item like TV, a preferred activity, but also using it when mom's attention's kind of diverted away to do other things and they want to maintain that attention, and so they're engaging in problem behavior. Okay, in this example, a child hits head, hand to head kind of hitting frequently throughout the day. In the classroom, they're observing it, at recess, at home when they're playing by themselves, and at home when they're actually getting attention and playing fun stuff with parents. They're not sure what's going on. It's kind of happening all the time across all conditions. What might be going on here? Yeah, sensory. So we do see kids that have really relatively high frequency. A lot of cases it's self-injury, and it can look like that, where it's relatively high rate, and when you stop to really look and analyze why this might be happening, it's happening pretty steady at pretty high rates across almost all environments. And when that happens, you maybe have to start thinking about some type of sensory, or what we would call the automatic function. So when we think about this, how do we get to this point where we can say things like this? I know that this child's hitting their head pretty consistently across all these environments, or I know that they're doing it only when mom diverts her attention. Well, we have to use what's called a functional behavioral assessment to get to that point that we can, pretty confidently say we know why this child might be engaging in this behavior, so that we can then move into treatment. And so a functional behavioral assessment is a process, or is a problem-solving approach that uses a wide variety of assessment procedures to identify the problem behavior. That is the function of the problem behavior, the why behind it. And so once you know the function, the goal is then to develop more positive behavioral supports. And I'll probably say this again, but I'll say it now. And the reality is once folks started doing a lot of thinking about disruptive behavior in the context of what's identifying the function, and started to develop procedures and processes for identifying function, people really started moving away from punishment-based procedures and much more towards reinforcing alternative types of behaviors that serve the same function as the disruptive behavior. So for a whole population of individuals, it really was helpful that we started using much, much more positive reinforcement-based procedures to treat their severe behavior rather than punishment. So how do you do this thing called a functional behavioral assessment? There's a couple of different ways, and I'm going to talk about those now. So there's indirect, there's direct procedures, and then there's the most intensive form of a functional behavioral assessment, which is called the functional analysis. The goal for all of those is the same: to identify the reason why a particular behavior is occurring for a particular individual. So some examples of indirect assessment procedures would be things like interviews with parents or teachers about the child's behavior, various types of questionnaires. Maybe some of you sitting in this room or in some of the satellites sites have done some of these. So that's kind of the indirect method. I'm remembering what's happening. I'm filling out some descriptions about my child's behavior. There are some standardized measures that have been published in the literature. It's just an example of some of those. We actually use the functional assessment interview form by O'Neill in our clinic, as well as the FAST, and I'll show you an example here of the FAST right now. The functional assessment screening tool by Brian Iwata and Willie DeLeon. This is just an example of a brief method to try to quickly get some understanding of why a behavior might happen. So it's some series of questions that you answer that kind of lead you down some of those functional categories that I just talked about. Kind of leads you down, well, it gives you examples here of the social attention function or the social function of preferred items or the escape function, or do we think it's automatic? And you can see some of those examples here. And then it allows you, at least this particular example allows you then to categorize it there in the far bottom right-hand corner into the various functional categories. So at least it gives you a very quick way to start to think then functionally what might be happening. There's some limitations to indirect assessment methods. Sometimes there's poor agreement, especially if you're doing it across multiple people, teachers and parents and grandmas and so forth. Sometimes there's inaccuracy because it does rely on memory. To say, oh, wow, last time, Johnny engaged in that tantrum, let me think, it was, 2 days ago, and what was exactly going on at that time. I mean, so it is this kind of, you have to remember back. There can be some inaccuracy there. But the reality is they're quick and they get you into starting to think kind of more functionally about some of the behaviors, like how might these behaviors be serving this child in the environment. So a few little suggestions here when you're using indirect assessments is, blend them with the direct assessments, at least some type of actual observation as well. Use multiple informants to try to get the biggest sample across environments of the child's behavior. And when should you only use indirect? Well, if for instance, if the behavior is very, very dangerous and you don't feel comfortable doing anything else, sometimes people disapprove of using different types of assessment measures and so forth. But I'll come back to this. But at the very least, when you're doing assessments like that, I would think that you would try to at least do some indirect and a little bit of just direct observation, just to kind of see what's happening in the natural environments. And so we'll talk a little bit about direct measures then. So direct measures are, parent or teacher or some type of therapist observing the child in the classroom, at home, to gain information about the when and the why the child engages in disruptive behavior. So rather than trying to remember back, although that's a good starting spot to have some of the indirect measures to start with, the direct measures are like the person standing in the back of the classroom, or the person trying to be in the home, just kind of observing how things unfold and observing some of the child's behavior under various conditions. And that can be really telling too, because what you do in those situations is what we call ABC data. So whoever's standing back there and parents that come through our program, we often will send them home with an ABC form to start to help us think about what's going on in their home, and they'll take data for us. And all it is really when a child engages in a behavior that's of concern, you jot that down, and then in the moment, if you can, or as soon as you can if you're dealing with a severe behavior, sometimes it has to wait for a little while, you write down what happened just before, what the behavior was, and what happened after in the environment. So what do they think was the trigger to it, like actually what was happening, and then how did they try to resolve the situation? And then they bring that data in and it can be really helpful to start to think and start to develop hypotheses about what's going on and why might this behavior be occurring within some of those functional categories that we've talked about before. And I did put here too, you can run conditional probabilities if you want to get fancy about it and say, hey, how often, what's the probability of certain behavior occurring following a certain antecedent or a certain behavior occurring just prior to a certain type of consequence. So this is an example. This is actually kind of a forced choice example where you might have the antecedents here, the things that occur right before the behavior, and they're all numbered 1 through 10, and then at the bottom there you can see that those numbers correspond to various things, like number 1 corresponds to academic demands being presented and so forth. And then you have a description of behavior, the frequency, and then when you see the behavior column there on the far right, you also have some forced choices, and then under consequences you have some numbers again that correspond to various types of codes at the bottom. But the forms that we often use in clinic are much simpler than this. It's literally a column that has antecedent or a column that has what the behavior is, and a column that has consequence, and it was just some lines, and you just kind of free text what you want in there. You just write. And so we can, when we do that, we get a couple things. One, we get the frequency, some like baseline data, like what's going on before we do anything. And then parents can just free text in, well, what happened just before that child hit me? What happened right after that? And then we get both of those, and we can start to develop hypotheses about what's going on when we don't have eyes sometimes in the home. So it can be more simple than this. So some limitations to direct measures. Sometimes they can actually be inaccurate when you compare them to more formal functional analyses data. Sometimes open time observations don't capture the useful information. This is the classic, you go out to a school to do an observation for an hour during a time that you think the behavior is going to occur, and the kid's great. You don't see it. So, and really when we think about these, the indirect and the direct measures are just correlational. They're not causal, they're just correlational. So we just have to keep that in mind. These events are just correlating together. But again, these two indirect and direct observation methods, in the way that we've just talked about them, can be very helpful to start to get you to think about function. And sometimes it's so clear when you see this that you can actually kind of go into some treatment. But for ones that aren't quite as clear, and we think that we need to do a little bit more intensive work, we can move on to a functional analysis. And so really think about the functional analysis as a way to test the hypotheses that you've just developed using the other two methods. So we certainly use interview data from parents, and they might go home and do some ABC data for us when we're thinking about some of these possible functional relations between problem behavior and the environment. And we use then, if we decide that we need to go on to do the more intensive functional analysis, we use that information then to develop hypotheses that we then test out using the functional analysis. And so this is really a way that we start to manipulate the environment, where you're messing with those front-end antecedents and you're messing with those consequences on the back end, and you're watching how the behavior changes in the middle. The most common approach was developed by Brian Iwata and his group in '82, where you can test several hypotheses relatively rapidly in a kind of a clinical setting, and you can compare it to control conditions. So let's talk a little bit about what an actual formal functional analysis looks like. We usually are doing these for when we get to severe behavior that's happening at a relatively high rate, and the other four methodologies that we just talked about, the direct observations where you're just watching but you're not manipulating, and the indirect methods, aren't all that clear, either because we think it might be automatic or we think there might be multiple functions happening here, but it's just not, you don't feel comfortable saying, I got it, let's move, you think you need some more assessment. And so the way that we run these is that you start to literally test out in the standard functional analysis, you literally start to test out the different types of your hypotheses about function. So in the attention condition, You set up a child with this can be run by parents or therapists, and they've been run a lot in different ways in the literature. But in our program, our parents run all of this. And so for us, it's a parent and a child in a room. We instruct the parent to divert their attention away from the child, doing something on their phone or reading a magazine. If the child engages in whatever behavior we're interested in, let's say some type of aggressive behavior or destructive behavior, then the parent will give attention in the form of a reprimand. Don't do that, that hurts me. And then they'll go back to ignoring the child again. And if we see higher rates in that condition, because the only way that that child can get attention is through disruptive behavior, then we're testing out that one of the gain functions, one of the positive reinforcement functions, that is this child will engage in disruptive behavior, this individual will engage in disruptive behavior to gain access to attention. In a similar fashion, the second type of gain function, that is the tangible, the preferred activity, we test that too, where that antecedent that we set up is that the high preferred activity is removed from the child if they engage in the behavior that we're interested in analyzing. Then the parent gives the item back for a brief period of time, and then they try to do it again. In our program, these conditions are about 5 minutes, but they can be longer. And that's a second form of that gain function, that positive reinforcement. With the demands, we work where we present demands to a child. If they engage in a behavior that we're kind of targeting, the activity is removed. And if we see higher rates under those conditions, that's the test for that escape function, negative reinforcement. The alone condition is how we test out for the automatic reinforcement. So this is a child who might be in a room with no items, no parent, nobody's around. There's no indication that anybody's going to be around doing anything, reinforcing anything. It's a very austere environment, and if that child continues to engage in disruptive behavior, a lot of times this is self-injury under those conditions, then we're starting to think about the fact that is there some type of internal stimuli, something going on inside that's automatically being maintained here. And then there's our control condition, and that's the toy play. So this is where everything's good for the individual. They have parent attention, they have fun stuff to play with, and there's no demands in place. And the idea here is that we shouldn't see a lot of problem behavior under this condition. And so what do we do with this data? How do we take data on this? And so what we do is we rapidly rotate this kind of standard. There's lots of permutations of this, but the standard functional analysis rotates through these conditions. These are like little probes that we're doing relatively quickly, kind of in this clinical setting, based on information that we got from interviews. And so we're trying to test out those hypotheses relatively quickly to see if we can kind of see what's happening. And so what you see here is this is just an example of a graph that we might create. And we have people taking live data in our clinic when they're observing the parent running these conditions. And this example here has aggressive behaviors per minute on that vertical axis there, the y-axis, and the sessions are there on the horizontal axis there, the x-axis. And what you can see is, well, what might we think about the function of this particular child's aggressive behavior? Why do we think they're doing it? Yeah, right. So every time that a parent tried to remove the toy from the child, got aggressive. Not so much when we tested out the other ones. So tolerated a lot of those other conditions. Relatively well, didn't see a lot of problems. But boy, don't take toys from them. So this would allow us to start to then think about, well, where do we want to start treatment? What condition? And again, this data shouldn't be totally alien to the parent too. So if the parent looks at that and is like, I don't know what you're talking about, that never happens at home, and I take toys from this kid all the time. Then we have to have the conversation with the parent about, well, what's going on here? Why would there be such a discrepancy? We typically don't see that, but it does need to match what the parent thinks is going on, or the teacher or whoever's helping us here. So this would be fantastic if I got data that looked like this all the time, but that's not the case. So sometimes it looks like this. So before was what we would call very differentiated or very clear results. This is what we would call unclear or very undifferentiated results. So interestingly here, even during that alone condition, if you can see that, problem behavior, this is again rate per minute, problem behavior all over the place. All over the place. So what's at least one hypothesis that we might start thinking about here? Automatic. Doesn't matter what we're doing. Even in the alone condition, when we left that child by themselves with nothing around, really trying to strip away, on purpose, strip away the environment and just say a child by themselves with nothing else going on, if they sit there to continue the disruptive behavior, a lot of times this is self-injury. Is there something internally that's driving that it has nothing to do with the environment? So, and so you can see where those different results would lead you down different treatment paths based on function. So some advantages of the functional analysis. It certainly provides the greatest precision and confidence in understanding causal relationships. And we do talk about causal relationships within the functional analysis rather than correlational because we're setting it up that way. We're setting up a specific antecedent and we're only reinforcing a specific behavior. And so if we see the behavior increase under those conditions, then we can say that there's a causal relationship between the behavior and the consequence. Disadvantages. There's a lot of technical skill involved in this. And sometimes if you don't do good interviews on the front end, because a lot of this, a lot of these are now being pushed out and done in community settings, schools, and so forth. But certainly if you're doing it in a clinic like we do at the Biobehavioral Program, if you don't do a good interview with teachers and families, you might not see anything, and you might not see anything because you're not identifying the full range of environmental variables that are actually triggering that behavior in the natural environment. And so doing some of those indirect measures, those interviews are really important, and even some indirect just observations are really important in leading up to a functional analysis so you have it right when you start to do some of this analysis and some of these testing of these hypotheses. An example here might be that you have some generic type of work and that child's fine with that particular work, but it's this certain type of work that their teacher gives them that you're not replicating in the clinic that makes them go off every time with disruptive behavior. And so you have to make sure you know that. The rationale for treatments based on function. As I said before, Dr. Rosenberg really in the next talk next month we'll really get into some practical treatment solutions. But you do need to understand the rationale for why we want to identify function first and why we don't want to just jump right into treatments. And really the idea here is that when you know the function of problem behavior, you can do things like break that relationship between the behavior and the reinforcement. Make sure that if you know why it's being reinforced or why it's maintaining, don't provide that type of reinforcement anymore. It sounds simple, but sometimes it's super inadvertent, and families or teachers or whoever just don't even think about it. They don't think that that's what's happening. And then the other thing that it allows you to do is provide reinforcement, the function-based reinforcement for an alternative behavior. So if you're not reinforcing the disruptive behavior anymore, but you don't stop there, you actually are setting now up reinforcement for some alternative behavior. You can change the trajectory of that child's behavior. Instead of doing this that doesn't work anymore, just do this down here, and it gets you the same thing that the problem behavior used to get you. And that's a super powerful type of procedure. And remember, this stuff is just a tool. And this is why I got into this in the first place, because when I saw this done correctly with kids that nobody else knew what to do with, it was incredibly powerful and really changed the lives of the child and the family when it's done correctly. So it's really a nice way to start to alter a child's behavior. And I want to point out again, I know I said this earlier, is that providing known reinforcement, not necessarily punishment. Punishment is ultimately a default procedure. It's when you don't know what else to do. you don't know the function, and so just try to punish it, and hopefully the behavior goes down. But if you can reinforce an alternative behavior that allows you to get the same thing because you understand the functional relationships of what the disruptive behavior is, it gives you a nice positive way to alter that child's behavior. This is just an example of all the different things that we can do once we kind of know what those functional relationships are. Again, Dr. Rosenberg will talk more in depth about some practical things that can be done at home, but you've got all these different types of reinforcement procedures for the different types of escape, tangible, and attention functions. You can still use something like a timeout at times in compilation with reinforcement procedures if you need to go there. And there's also similar types of things for the automatic functions. So here's just another little example here. 16-year-old boy, autism, is nonverbal, engages in aggressive behavior at school, and often hits the teachers. Results of the functional behavioral assessment show that the child's disruptive behavior is occurring because it allows escape from work when he starts hitting others. So they've done some variation of the different functional behavioral assessment procedures that we just mentioned, and they identified that it was this negative reinforcement or escape function. Well, what do you do? What's a function-based treatment? Well, one is what we call functional communication training. So you might be able to teach that child, rather than hitting, to, for instance, touch a break card to get a work break. And when you start something like that, they get a break immediately. The goal isn't necessarily to get that child to work. The goal is to get them to start to use a function-based communication that's more appropriate than hitting. And then over time, if that child is using it excessively, and I get this question a lot when I talk about functional communication, teachers and others might say, well, if we do that, he's just going to touch it all the time, and then they're never going to get any work done. Exactly. But that's your first step. Your first step is to get rid of the disruptive behavior and build a new behavioral history. And it's not when work's presented, I hit you when I get out of work. It's work's presented, I see that break card, I touch it, and then I get out of work. And then I see it again, and I touch it, and I get out of work. And then once you get some momentum going in the right direction, kind of this behavioral momentum through that reinforcement process of using a communicative response to get out of the work, then you can start to fade in work later. And that child will tolerate it more because you've got this new history going in the right direction. And then you can start to say, there's various ways to fade it in, but one way is great job, now just do one, and then you get a break. But now you've got a little history. If you try that right away and you try to get them to do a little bit of work by touching it, they're just going to go back to what they know, which is I can hit you and just get out right away. Why would I do work? So you have to it's a process. And so a lot of times when I'm talking to parents and teachers and so forth, explaining that this is just the starting point. It's not where that child's going to end in a year from now, the treatment that we develop now. It's a process of getting them there in this kind of way of shaping behavior. So that's just one example of how we might use a function-based treatment. So just talking a little bit about functional behavioral assessment in individuals with autism, functions of problem behavior related to specific behaviors associated with autism. There is some research that has come out in the last several years where they're looking at things like, this would be an example of where you really have to pay attention to that organism variable that we looked at before. Because kids with autism and kids in various different kinds of categories, diagnostic categories, they come with some real biology that's kind of there. One thing we know about kids on the spectrum is some of them can have pretty rigid behavior and engage in repetitive behaviors. And so you could look at, kind of within the context of function-based assessment and treatment, things like escaping demands that might interrupt some type of repetitive behavior, or escaping certain types of sensory stimulation. So noises, forms of attention, that's kind of a special escape function. But I've worked with lots of kids that they go into a noisy or hectic environment. Sometimes it's even the waiting room of the autism center. That in and of itself is an environment that will trigger a tantrum, and if they then can leave that setting, or if at school, if it's super hectic in their classroom, they can leave that setting, then they calm down. So it's this kind of specialized escape function that's kind of specific to kids with some sensory sensitivities. that maybe another child might not have. Regaining access to a specified routine for kids on the spectrum that might be really routinized in their behavior. Okay, so I just want to show you an example of how the functional analysis process can kind of be tweaked to look at some of these types of things. So I kind of showed you the standard functional analysis, but that was in '82, and there's been so many permutations of the functional analysis and functional behavioral assessment since that time. This is just an example of some folks that looked at some destructive behavior in a couple of kids with autism, and this is just one example where these kids were engaging in what appeared to be automatic destructive behavior. They were just breaking things, just breaking plastic things. That's why they came to be assessed, because they were so destructive. Well, after they observed some of this stuff, they saw that they were breaking these things, and then they were accessing the pieces, and then they were engaging in stereotypic behavior with the small pieces. And so they looked at that, and you can see here in the red rectangle that I made here, this is that the rate of that stereotypic behavior, taking those pieces and flipping them around and looking at them in different angles and so forth. And it's pretty high in baseline. And then they gave them access to some broken pieces. You didn't have to break stuff. I'm just going to give you a whole bunch of broken pieces already. And it just kind of maintained it at similar levels. They went back to the baseline levels where they had to break it to get it, and then they went back again, and it kind of maintained. Now, if you look at the bottom part of this graph, that's the property destruction. And what you see is this looks like a relatively simple idea, but these kids came in because they were so destructive, and people weren't across lots of different settings, and people were not understanding why. Because it doesn't fit super nicely into those functional categories that we saw before, but really this just ended up being kind of this supercharged, tangible condition, right? Access to high preferred pieces of things that they like to engage in stereotypy with. And so when they gave them free access to those things and they didn't have to break them, it's just a little front-end kind of strategy. You can see by the end, in that last phase where they just gave them free access to the broken pieces, they weren't breaking things anymore. Now, they still had other stuff that they could break in the room, but as long as they had their little pile of things, that they wouldn't break them. And so this is just an example of ways that they were kind of tweaking some of the basic functional analysis idea around what they thought was kind of a specific idiosyncratic function. Here's another example. This was a child with Williams syndrome, and kids with this syndrome can have be very sensitive to noise. And so they had some hypotheses about why this child was engaging in problem behavior, and they ran some of these little conditions. You can see the demand condition or the attention condition, and then the play condition. So they were kind of doing this functional analysis and testing out some ideas here. But the interesting thing about this one is if you look at the kind of the phases here, no noise, no noise, no noise, noise. What they actually were doing when they were running this is they played a tape recorder in the background of background classroom noise. And when that noise was high, what you saw, when there was no noise, you didn't see any problem behavior. But when the background noise of a hectic classroom was there, you only saw disruptive behavior occur under one condition, and that's when task demands were presented. So it wasn't just across the board. And you can see that here replicated in the yellow or in the red circles. So for that particular kid, there was this interesting interaction. And the interaction was, if it's noisy and you give me demands, I engage in problem behavior. If it's quiet, I can tolerate it better. So this was an interesting analysis because it really started to show some interaction effects between some of these types of environmental variables and some of the biology of this particular child's syndrome. And so you had replication there, and, hey, they taught them to put in earplugs, and it worked. But again, you might not know that because it seems like a no-brainer when you see it like this, but when everything's changing at once in a natural environment, that might be a really hard interaction to actually observe. But once you know it, some of the treatments seem relatively simple. So in conclusion, we have to think about functional behavioral assessment is really a process. It's not a specific procedure. There's different procedures that go into it, but the idea of a functional behavioral assessment is this process of trying to evaluate the function of disruptive behavior. That is the process that examines how environmental variables impact problem behavior. A lot of times that process does move from kind of this least to most intensive, so interviews to functional assessments or functional analyses. And then the functional analysis allows for the most precise treatments that really allow you to interrupt the response reinforcer relationship and avoid inappropriate treatments. And some of that's really important too, and I didn't touch on that as much, but if you get it wrong, these treatments aren't necessarily benign. So if you think a child's engaging in problem behavior to get attention, and really it's escape from work, and every time that child engages in problem behavior, you put them in a timeout and remove work and they get to go by themselves and do nothing, you actually might be reinforcing it if you have the wrong function. So that might actually be increasing it, because that child's like, hey, every time I want to get out of work, I just need to hit the child next to me and I get out of it, or hit the paraeducator or something, and I get to go over and sit by myself. And that might not be super fun, but it might be better than the work. And so it's really important to make sure you are matching treatments to function. Oh, hey, pop quiz. So I always loved popped quizzes when I was in school, so I decided to give one. So just to reiterate, really getting you to think about function and not what the behavior looks like. I threw up a couple examples. So Emma's a 10-year-old girl, autism, nonverbal. At home, every time her mother attempts to answer the phone or to help her younger sister with homework, she starts to bite her hand hard enough to cause bleeding. What might we think about the function that's happening in this? Yeah, access to social attention. Even if it's not positive attention, even if the mom is saying, Emma, stop biting your hand. Look at your hand, you're hurting yourself. That might not be super positive attention, but it's attention. And if I just want attention, I want attention. And so sometimes kids can learn to get even attention if it's not great attention, especially if, everybody gets busy. I have 2 children of my own. I'm guilty of this myself. You get busy, and when your kids are good, what do? Whew, let me go get some other stuff done. And so really sometimes what we do is we teach our kids that if you're really good, you're going to get ignored for long periods of time because I got other stuff to do. But if you start hitting your sister or biting your hand, then I'm going to come over and I'm going to talk to you. And none of us think about that, and I'm guilty of that myself with my own kids. And boy, they take full advantage of that sometimes. So it's a slippery slope sometimes, and so that might be what's happening here. So in the next one, Tommy's a 6-year-old boy with developmental delay, nonverbal. At school, he hits his teacher when they try and get him to complete schoolwork. He loves play at recess, and he also hits every time they try to bring him back into the classroom. So what do we think is happening here? Yeah. What else might be happening? I like recess. Yeah. I really enjoy those swings, and when you move me away from those, that's a problem. So we have to remember, too, that it's rare, actually, to get a child who's engaging in problem behavior for a single reason. Sometimes you get it, but a lot of times, if it works, they try it for other things, too.
What was your answer to that one again?
Escaping non-preferred activities, and maybe trying to maintain access to some of the play activities at recess. But you can see if you do some assessment here, and then you've got these hypotheses now in your head, even if you didn't do the functional analysis, even if you just did some observations, you did some good ABC data and some interviewing, or if it's your own kid, just thinking about it yourself. And when parents often will come back when I have them do the ABC data, and they're like, I'm kind of thinking about this differently now. So just sometimes the process of taking the data really kind of makes you look at what's going on differently. And then you're like, I didn't notice that before, but now I kind of see what's happening. And that's really powerful. And then you can start to think about, well, I see that even if you're not doing the functional analysis with all the data and everything, if you're looking at ABC data, but it is still a process, and it's still that process of systematically tracking behavior on the front end to develop ideas about what you think is happening, rather than just launching into treatment. But if you take some of this type of ABC data over a couple of weeks, and you get together and other people, if you're with your spouse or with the teacher or something, and everybody's kind of on the same page, like, yeah, we really think maybe it's this escape or maybe it's access to attention. Then trying some function-based treatments, and you can kind of do this response to treatment. And then you say, we have some data. It gives you frequency. So we have a little baseline, and we're going to try some stuff that we think is function-based. And does it go down or not? And we're going to track that too. And if it doesn't go down, then either it's not an effective treatment or you missed the function. But if it does go down, then you got it. So it can be more simple, and families can do this stuff. So just a couple of tips here. Behavior intervention plans within the context of individualized education plans. Just some things to look for, to be savvy about it when you go into IEP meetings, and they're specifically when schools are developing behavior intervention plans, is, IEPs, they need to have academic skills and goals that are tied to academic assessment. So every 3 years, you get reassessed. So there should really be data to show that your child is engaging in academic or some type of academic skill that's at their level, based on some of that testing. It's not super low or it's not way above them, because clearly we all would know that if you get a kid who might be engaging in escape maintain behavior, one of the first things you say is, well, what's the tasks that are being asked of that child? Can they do it? Do they have, so you do need some assessment on that end too, just from an academic and skill-based perspective. When you're getting into the disruptive behavior, a behavioral intervention plan should be based on the results of some type of functional behavioral assessment. That's law. A lot of times what I see in schools is some type of indirect interview that a teacher or somebody fills out. Ideally, those would be indirect interview, and at least some type of objective observation. Not necessarily a functional analysis where you're manipulating the environment, but at least where you're doing some ABC data. Somebody's in that classroom doing ABC data. And that kind of matches up with what folks are saying is occurring. And then once you have that data, it needs to drive the intervention. And sometimes I see a disconnect there. Like a functional behavioral assessment was done, and then I read the treatment components, and it's just like a template that has nothing to do with the data that they just gathered, even though the data seemed almost it seemed good, like, hey, they have some real hypotheses here about what's happening, but I don't see that reflected actually in the treatment components. And so the treatment, when you're thinking about it, if that child, for instance, has escape maintain behavior, then the treatment plan specifically should have components that are addressing how they're going to increase compliance. And how they're going to use things like reinforcement, or they're going to alter the work or whatever. Or if they think it's attention, how is a treatment plan going to address the attention? Are they going to teach that child functional communication, to touch a card, to ask for teacher or peer attention? How are they going to address it? So it really needs to be tied functionally to what the data suggests. And then, data should be taken on once that intervention's in place. Is it doing what you think if it's supposed to decrease problem behavior, is it or is it not? And then it's kind of this response to treatment. And if it's not, I always tell families, behavior doesn't lie, it occurs. So if it's our job to try to figure out how to alter it, but if it's still occurring, it's still occurring. It's something isn't right, so we have to alter it. We don't just keep kind of doing the same thing over. We have to make some data-based decisions about why we think that might not be occurring. And so those are just some hints as you think about working with IEP teams and so forth. Okay, I have till 8:30, right? Okay, great. So now I want to, before I actually move into this, does anybody in the audience have any questions? Yeah.
With the graphs that you showed, are those for each specific behavior, or those like disruptive behaviors in general? Like, is it, breaking pencils versus climbing on tables
Yeah, so that,
Two separate graphs, right?
oh, yeah. So the question was, in the graphs that we looked at earlier, what behaviors were we looking at? Was it behaviors coupled together, like is destructive behavior, swiping things off a desk and breaking a pencil and throwing things across the room, or is it separated? And that question goes to how we define behaviors, and that is a very important first step when you're starting to analyze things. And in the graphs that I showed, it was labeled on the side, like for that one child, it was just aggression. Now, what is aggression? It's defined. Aggression might be, and we do this in our program too, we'll usually define it in a category. Like aggression might be hitting, kicking, biting. Destructive behavior might be swiping things off the table, throwing a pencil, not at somebody because we'd call that aggression, but if they just throw it, that, breaking items, breaking toys or whatever. Self-injury could be a bunch of things too. I hit my head with my hand, I bite myself, I bang my head on the table. It depends. The reality is it depends on how much you have to break those things apart. Like, do I need to take self-injury and break it into 5 different types of self-injury? And the depends here is, do I think that those things, based on interview, based on some of the just observations, do I think those things are occurring for the same functional reason or not? And it's when you really get really technical with with kids that might be engaging, like self-injury is a good example. I've worked with kids that have a wide array of self-injury that they'll use. Many, many, many different types of self-injury. And we've done actual functional analyses where we've had to break down each individual type of self-injury, and you can see through some of the more intensive functional analysis work that different types of self-injuries occurring for different functional reasons. And then, so it can get that kind of nitty-gritty with some of the stuff. And so what I would suggest is that if you're starting to even just do some of the interview and some of the observations, is that you have to start with a good definition. And anybody helping you in doing this, you have to be on the same page. So when we say destructive behavior, what are we saying? Is that really what we're looking at for this child? Is that really the behavior, or is it really aggression? What is that when we're calling it aggression? And you get, if you don't get it right the first time, we often will do things where we aggregate the data too much at first, and we're like, oh, let's put it all in one lump. Like aggression has 5 different types of aggression. And then we start to run some analyses, or we might have the parent start to take some data at home, and then we're like, ooh, let's stop and break that apart now, because I actually want to see that. So the model's flexible too in that way. So it really, the answer is it depends. It depends on whether you think it's all occurring for the same reason or not. Yeah.
And would you say you had a friend, come in and help you? So I understand, like, if you're in a clinical environment, somebody could be watching a two-way mirror or something, so you say that you leave them alone by themselves.
Yeah.
How would you do that at home by yourself?
Well, if you get into the functional analysis part of it, I would say get a board-certified behavior analyst to help you.
So what if you have somebody who doesn't have access to that?
Then if they can get to a clinic or someone that can do it, or if they can get some type of telemedicine, because when you're getting to that level where you're actually doing the functional analysis work, you are getting in, you do want somebody to help you. You don't want to get into a quagmire with the data. And if it's not working out, if it's super clear, if you get that really clear functional analysis, then you're golden. But if you don't, and you don't know where to go from there, and there's no, there's nobody to help you. So once you get into the functional analysis, at least some type of consultation, even if it's not on site, you should be seeking out some type of consultation about where to go. I mean, if people are living in places that are so remote that they can't get to a facility to do some of that stuff, if we think that's necessary, some type of telehealth alternative, or some type of consultation in some form should be done, just so you have somebody with some training in doing those more intensive types of functional analyses, is what I would suggest. And the reason that I say that is that it would be a bit irresponsible for me to send somebody home to say, just go try some of this functional analysis at that level where you're actually attempting to kind of evoke disruptive behavior so that then you can track it without some real knowledge about how to do that in more of an intensive way. Is that okay? Okay.
So I had a question that was kind of about functional analysis in a clinical setting with parents involved. Because you were talking about having the parents in the clinical setting kind of being the ones who are giving the stimuli or whatever.
Mhm.
So I was just curious about that, how you train those parents and what kind of goes into preparing parents to be the ones to evoke those behaviors.
Yeah, so
Rather than encourage.
yeah, just to repeat that question. How do we prep parents for conducting functional analyses? Well, we have a whole, but before we start to run, we have visits where we go over a lot of this information, and we're prepping them for what's, the rationale for, yes, we are actually going to be trying to see the behavior so that we can see the pattern. It's going to be based on these. We go through the interviews and all these other things beforehand, and so the parents are with us developing those ideas because they're the ones that are reporting to us. And then in our program, we have bug in the ear technology, so we have the ability to sit behind a piece of glass and talk to the parents with a bug in their ear, and we can pull them out in between sessions and all kinds of different things. And we set up so each time you see a condition, we're setting that condition up for the parents, and we're kind of coaching them because we're kind of chirping in their ear the whole time. So there's a lot of kind of leading back to the previous question when we talked about, how would we do a functional analysis at home? When parents are running those functional analyses, there's a whole bunch of guidance because, we're really trying to make sure that they're keeping everything, the way that, because we're scripting them, right? We are scripting them on purpose, and we're kind of taking the environment and deconstructing it in a way so that we can test these hypotheses individually.
I think where I was maybe coming from more was a friend of mine has a very similar situation, but she has zero insurance coverage for it. So she's trying to figure out what can they do on their own.
Yeah.
And so it's just
Yeah.
sort of a.
Again, I think that I would do, yeah. So again, the question was, well, in this particular setting or this particular incident, there's a family that insurance unfortunately doesn't cover any ABA. It sounds like, and the parents are left. What do I do? So what do I do here? Again, I think that they could probably start with some of that ABC type of data, and it doesn't need to be fancy. It just needs to be the thought process, and it is, I'm going to start to really intentionally look at my kid's behavior. I'm going to, as we talked about earlier, we're going to make sure that we define it. So whatever the behavior is that's of concern for mom is the same for dad or for grandma. So you want to define it. It can't be, if it's something like, I want to stop his tantrums. Well, what's a tantrum? Tantrum might be something different in mom's eyes versus dad's versus grandma's eyes. So you don't want to define it that way. You want to say, I want to stop his biting of people. He's biting people. He's biting grandma. He's biting me. We want to stop the biting. And he also, during those times, flops to the ground and screams. We want to stop that when it's occasioned by biting. And so you want to get down to that so that everybody that's taking that data is taking the same data. Because otherwise it can get murky, and it's, make sure everybody's on the same page. So defining it. And then just going about, it's occurring in the environment already. So all you're going to do now is pay attention to what you think is triggering it, those antecedents on the front end, and what are those consequences on the back end. And again, through that, and just by being more mindful of that, you start, parents are really good at this. They come back and there's parents that are kind of like, okay, well, I'll try that. And then they come back and they're like, oh boy, let me tell you what and they just thinking about it at that level starts to really, they can already start to see patterns that maybe they weren't seeing before just by being more mindful. And that makes sense. There's all kinds of examples of if you're just more mindful of a situation that you kind of look at it differently. So, and then, if they can start to think about those functional categories that we just talked about, is there any type of attention? Remembering that sometimes negative attention a parent yelling at a kid is still attention if that's what they want, especially if the antecedent was, I was over here helping their sibling with something, or I just answered the phone, or something like that. Or is it demands, or is it access to preferred stuff? And then they can try some stuff. Again, I would certainly recommend some type of supervision just to kind of get some coaching as you go through it. But if they're really, really, limited resources, they really can't do that, then just trying to get an idea of some functional behavior through the ABC observational data for a couple weeks to just give them an idea of what's happening, and then maybe trying some stuff. And then just keep what's the response to treatment? Is it decreasing the biting, or is it not? And if it's not, something else is happening. Any other questions before we move on? Okay. So I just want to talk a little bit about our services at the Autism Center, the Biobehavioral Program at Seattle Children's in general. So we use a biopsychosocial model. I think I'm okay on time here. And where, we get kids, we're housed in the Autism Center, but we don't get kids just with autism. We get kids that might have some other type of developmental disability or something, or some other type of genetic syndrome and so forth. But the main issue is severe behavior. And so we certainly need to be looking at the kind of the biologic and medical side of things. We also need to look at skill level, communication level, those types of things. And then there's, the more pure behavioral lens that we can use in the way that we've been talking about today. So we really start to think about, and what we're trying to build here is a continuum of services. And what you see here is kind of the scope of our program so far. Excuse me. The blue is the stuff that we have in place, and the orange is what's coming. So we have an interdisciplinary clinic, the Biobehavioral Assessment Clinic, where we get together a behavior psychologist, a speech and language therapist, and either a psychiatry fellow, psychiatrist, or a psychiatric nurse practitioner participates in that for the medicine side of things, where we see kids all in one day. We get multiple eyes on those kids, and we get to come up with some ideas about assessment and treatment that, how to move forward with treating this child's severe behavior. It's not treatment in and of itself. It's just to give the parents an idea about where we think that they should be going next through all these different perspectives, and we get a chance to chat as a team when we do that. We also have a couple of different outpatient models in the form of behavioral consults. We have a standard outpatient, and then we have a more intensive outpatient, and I'll go over the details of these in just a minute. And to come, things that are slated to come here are a 5-bed inpatient unit on our inpatient psychiatric unit here, and we also are getting contracts to go into home and school to do some generalization support once we've done some of the work clinically here, to kind of move that and have teams that go into the homes and communities with families to kind of help them run those treatments in those natural environments. So quickly, the Biobehavioral Assessment Clinic, I just mentioned, it's the typical patient that comes through there is more highly impacted, higher rates of disruptive behavior, can have more complexity as far as medical and other things going on. It's a single day clinic. Everybody sees the child in the morning. They kind of rotate through all the different disciplines. Then we get together at noon, and we get to chat about what's going on, and then we do feedbacks in the afternoons. And this is just a nice team approach for severe behavior, where we get a lot of people looking at these kids. And a lot of times that's a funnel into our program. Then we get to say, and we want you to come back in these various ways to see us. The behavior consult track is a briefer track, 13 visits. These are kids that might have either lower rate problem behavior, less impacted, behavior might not be quite as severe. And the goal here is to really conduct some functional behavioral assessment, kind of in the more indirect way. So interviews, unstructured observations, a lot of ABC data. We have parents do a lot of that for us in this track. And then we help the the families take that information, develop function-based treatments based on the hypotheses that have been developed, and then we help them troubleshoot the plan. And so this, the previous questions about, well, if I can't get ABA therapy in the home, how can we do it is there any other kind of options? And this is where that consult model comes to, where nobody's going into the home, but the parents at least have a sounding board to kind of say, hey, we tried this, and it looked like this, and then we kind of help them troubleshoot it as we move through things. So. Our standard outpatient is a bit more intensive. Again, higher rates of problem behavior. Kids are more impacted in various ways. 23 visits, we see them once a week. This is where we actually, in clinic, we start to conduct the functional analysis, the more intensive functional analysis using single case design. We also then use the information from those functional analyses to develop treatments, and then we test the treatments and evaluate the treatments in clinic too. Parents are doing all of this. Then once we see from our data, kind of in the way that you saw some of the data graphed here, that we have something that works, we help the parents go home and do practice sessions and start to move it into the home. And like I said, in the hopefully not too distant future here, we're actually now going to have a team that we can hand it off and say, now work with our in-home team to help you practice and move this into the home and community to really start to get this kind of rolling in the home and community. But here's just some data I'll show you from one of these more standard outpatient models. This was a little guy that came to us. He was little. He was about 3 and had some developmental delays, nonverbal, really engaged in a lot of face and hand hitting and head banging. And so we ran a brief functional analysis here. And in that first phase, you see where we did the functional analysis. And it was pretty clear. So if you look at our legend over there, you can see who thinks they know what the function of this little guy's behavior was. Access to mom's attention. But it was so bad, she could, even if she was holding him and turned away from him, he would immediately start engaging in self-injury. So this was a little guy who, when we saw him in the lobby, when mom was checking in, holding him, checking in, he was engaging in all kinds of self-injury right in mom's hands. So, we assessed that. He did pretty good on all these other things. So when we gave him task demands, he was okay as long as mom was with him. When we took things from him, he was okay. He could transition to other stuff as long as mom was with him. But if mom tried to divert her attention away from him, that was a big problem for this little guy. You can see that we do, I didn't need it. I stopped. These are only 5-minute sessions. I stopped after 3 minutes because it was clear on that one, and I didn't need to see any more self-injury. So what do we teach him to do in that second phase? FCT is functional communication training. We taught him to touch a card. It was actually an iPad with a picture of mom's face on it. And you can see there that in that little data path that says MANS is just a fancy way to say requests every time he touched it. So what did he do? Problem behavior went to 0, and he started to touch the picture of mom. And mom gave attention right away. And then we wanted to make sure it was what we did, so we reversed back to our baseline, and we got a little bit of problem behavior, but not as high as before. And then we went back and put our treatment back in, and sure enough, the problem behavior dropped right out, and he started to request again. And then in that final session, we started to teach him to wait a little bit, and we started to introduce a timer. Great job asking, now you just need to wait. So then we start to teach delay to what you want specifically as a skill. But we wouldn't have got there if we tried that right away. So we only got there once we taught him and started to develop that new history. So that was done in like that 23 block. Now this wasn't the whole story, right? This is, you have to remember that all of these treatments, this is just the start. This is just a way to get us, these are brief, we see these families relatively briefly, but it's a way for us to get in, look at them from a functional perspective, set up some functional-based treatments, start to get the ball rolling. But really it's the families and any supporting professionals out in the community that are going to keep these things going in the long run. And that's the kind of the work in the trenches that needs to be doing. But if we can do some of this analysis to make sure that we can take away the doubt from families about, am I doing the right thing, or should I be doing something over here? If we can say, this is it, we got it, we show that this is the function, just stay with it. Because I wish behavior change was this nice linear line, like, oh, you do a treatment and something works great, but it's all over the place and it can be sloppy and different things can happen. But you need to take data and look at trends over time to make sure it's still going in the right direction. And that's some of that guidance I think that's so valuable over time, is to make sure you look at trends. And that, ultimately that's why we take data, because if something goes horribly wrong and then you come to see me and I say, how's it going? You're going to say the treatment doesn't work. But if that day, the next day was great and I saw you on that day, you'd say, oh, things look pretty good, because we all get lost in the day-to-day. Everybody does. That's why we take data, because it's the trends that matter over time. And sometimes you don't see those on a day-to-day basis. Intensive outpatient. This is where we try to do the same thing that you just saw here, where we're doing more functional analysis work and treatment evaluation. We just try to squish it down, and we do it in 10 days, 2 hours a day, Monday through Friday, and we try to get through it all as fast as we can, because 23 weeks is a long time. So we try to do it more intensively. Same idea. I'm not going to go over this in detail, but this is just an example of what we did with one little guy where it got kind of tricky with our analyses. And so you can see here we're doing all kinds of stuff. The end result here, though, is that we thought this young man was engaging in some automatic self-injury, and it turned out not to be automatic. It turned out to be mostly escape. So we differentiated some of that through that. Some inpatient stuff. Here's the general specs on the inpatient unit that we're hoping that there'll be longer admissions for pretty intense kids, where we're just doing a lot of this on an inpatient unit with more support. The example of one kid that we did go over and run on the inpatient unit with, this was a couple years back, 12-year-old girl, minimally verbal, autism, had some really severe self-injury. This was, as we mentioned before, this was a young lady who had a lot of different types of self-injury, so tried to hurt herself in a lot of different ways. She'd had a couple previous admissions to inpatient units. When we saw her, they were adding more and more protective equipment just to keep her safe. She had a helmet with a face shield. She had rigid arm splints. She had padded gloves because she'd bang her hand. She had padded shin guards because she was kicking herself in the shins and so forth. And so, again, I'm not going to go over this in detail, but we ran in the top panel there. You can see we did a whole bunch of functional analysis work around self-injury. She was someone who also wanted to hold people's hands all the time, so we had to do a couple of permutations and manipulations of the functional analysis. The end result actually was at the end of the standard functional analysis, it really looked like it was an automatic behavior, until what we did in the bottom panel is looked at within each session analysis, and we saw that the behavior was going down across some of these alone conditions or these ignore conditions where you would look at the automatic function. The behavior was decreasing over time, and if it was automatic, it shouldn't be doing that. It should kind of stay steady. And so what we identified really was a interesting function of, she wanted to hold your hands all the time, and it was like the supercharged tangible situation. And so what did we do with that? Well, we taught her to ask for that, and and we'll give it to you right away. And so in the green data path here, that's the level of self-injury. The blue is the requests. She had some verbal ability, so we just taught her to say, hold your hands, please. When we did that, we initially got some good decreases. We reversed back to our baseline, and it kind of came back up. We put it back in place, and we thought we were doing pretty good. But in this phase here, so 1, 2, 3, 4, the fourth phase, treatment phase, we started to kind of lose the control right there where problem behavior came up. So we added something, and what we added was a little timeout condition in that next phase, where if she hit herself, or if she or if she asked for us to hold her hands, and then when we were trying to do that, she hit herself, we would remove our hands and she'd have to ask again appropriately. And when we started to do that, we got it to decrease, and then in the latter half there, you can see that we brought in mom and dad. This was on an inpatient unit, so we were actually running it. But then we brought in parents, and they started to run it, and then the very last little data point there is when they came back to see us in outpatient a couple weeks later. Now again, this was just the start. This was not the end result, and everybody went on. She still had struggles, but what we were able to do is work with an in-home team. And, she had very severe self-injury. This was a very severe case. And we handed those graphs over to board-certified behavior analysts that were running the in-home program. And we said, here's the function. It's not actually automatic. It's this hand-holding. And then we helped them develop some strategies that they worked with the family for a long time to kind of start to thin out how long she would hold your hands and what would she do when she wasn't holding your hands. Before, it was just hitting herself. But what else was she doing? But this was the first way to start to tease apart actually what was happening. So, common obstacles for parents. Okay, man, this is a big slide. I forgot about this one. We want to look at ABA school or ABA programs that they request a functional analysis be completed. When a behavior intervention plan is developed, so some type of functional assessment, really that should say functional behavioral assessment. IEP and program goals should be developed that target decreasing problem behavior. And again, that goes back to sometimes we don't see that. There's a kid with an IEP that has severe behavior and there's no behavior plan in place. And so we want to make sure that those get in places. Function and teaching functional replacement behavior, again, hypotheses should the treatment should match the hypothesized function. These are just some general comments. So remembering that the use of restraint seclusion, there's a mandate now that you can't use that except for emergency situations, and so this is just things to be mindful of. You can use it in like an immediate danger to self or others type of situations. Getting assistance, just some information up here about how to get assistance with if some of the things that we're saying you don't see schools doing or you as parents are having some problems with school teams. There's some information here for how to, at least within the state of Washington, for special educational ombudsman and so forth. Sometimes teachers don't, feel like they're trained enough in some of this type of stuff, and so just reaching out to parents or teachers and asking for more training in some of these models, the whole idea of functional behavioral assessment and how to do some of that stuff. Some of you, I'm sure, know this, but DDA does have waiver systems that will provide you money to bring in behavioral folks into your home to help do some of this kind of work. And then here at the end, and this kind of leads to your question of if insurance is not covering ABA, the Washington Autism Alliance, is there are phone numbers there, and they can really help with insurance companies and why they're not, they're a parent advocacy agency that's built specifically to help parents work with insurance companies to get some of this stuff covered. And I think that's it. I ran a little long, sorry, but I will take some questions from other sites or in-house. Okay.
Excellent. Thank you very much.
Thanks, everybody.